Hello, my name's Lexi Adkins. I work in the emergency department. I am replying to the video of Brennan Smith about DVTs. So in the emergency department, it works a little bit different. It's interesting hearing your side from an outpatient clinic versus my side, which most of the time ends up being inpatient. So the symptoms pretty much are the same. Patients usually come in, complain of unilateral pain in one of their legs. And a lot of times these patients have like coexisting factors. So they'll have like a clotting disorder. They'll be somebody who doesn't move around a whole lot. Sometimes it's somebody who like went on a long trip, so in the car for a while. I've seen that a couple times. But usually the symptoms show the same, the unilateral pain. Treatment wise really is a lot different actually, and I was a little surprised by that. We most of the time end up putting these patients on heparin drips. Again, that kind of goes with the inpatient side versus the outpatient clinic. The lab work is the same. We do all of the coagulation labs, so the PT, PTT, INRs. We'll do just basic labs to see if there's any issues other than the DVT, and just to try to figure out why this patient is having a DVT, especially if this is a chronic issue and this is not their first time. So we'll do the same workup pretty much. The heparin drip, again, we start that on pretty much everybody, and that's first line of treatment in the emergency department. So it's kind of step one. We'll do the anti-10A labs, so that'll kind of be our baseline. We'll start with a bolus of heparin, and then we'll move on to the heparin drip, and we'll do those anti-10As every 6 hours, just to make sure that their coagulation therapy is working the way we want it to. And that continues as they go upstairs. They'll get admitted, end up upstairs on the heparin drip, and they'll continue that 6-hour mark, drawing that anti-10A level. Things we would look out for, of course we have to check for pulses, and this is pretty often. We try to do this every hour to 2 hours, checking for pulses as much as you can, just to make sure that that DVT doesn't become occlusive and stop blood flow below the clot. We also, of course, would be worried about embolisms, so we would make sure the patient's on a monitor, they're breathing okay, they don't throw a PE or something like that. And all this is usually within a few hours. Usually have these patients for quite a while, keeping them inpatient, just making sure that no complications arise and that we're getting their coagulation under control. So yeah, again, I was really surprised that you all really first line of treatment don't send them to us or to an inpatient clinic for the heparin drip, because for us that's always the first thing we do. I've only seen a few times where we do outpatient therapy and just send somebody home on something like Xarelto or Coumadin, something like that. So yeah, I was a little surprised by that. Thank you for your information. Again, it was really nice to hear somebody's perspective from the other side, outpatient.